Hello, my name's Ken Kinter, and I'm an assistant professor at Rutgers University. The purpose of this presentation is to provide an introduction to something called trauma-informed care. As always, my contact information is at the bottom of the slide. Don't hesitate to reach out. And there are many other videos that are similar to this in the series. I welcome you to check those out as well. Before I get started, just wanted to give a shout out to the New Jersey Department of Health. They have been funding and supporting the State Hospital Psychiatric Rehabilitation Initiative from Rutgers University for many years. Our mission is to improve the quality of care and working conditions at New Jersey State Psychiatric Hospital for the patients and for the staff. And without the Department of Health support, our mission would not be possible, so we thank them for that. Now, about what we're going to be covering today, we're going to be covering a lot of ground, but mostly about trauma and how that trauma can develop into something called post-traumatic stress disorder, which I'm sure you've heard a lot more about. We're also going to talk about something called the Adverse Childhood Experience Scale, which is something you can find online, but we just wanted to give you some information about it. And then also provide an introduction to something called trauma-informed care. In the 30 years that I've been working in the mental health care system, we've gone from what was called the medical model into something called the recovery model, which is much more about the person being at the center of their care and making decisions about their care rather than having care decided for them. Now, the second big move that I've observed is this move into trauma-informed care. I've also heard it called trauma-centered care, really looking at trauma as one of the primary drivers of medical illness, mental illness, and addictions. And we've sort of avoided this orientation at our peril for a long time, or maybe we're just getting better at what we're doing, so we're able to get into this deeper. So first, let's talk about trauma. I'm sure we've heard the words trauma and traumatic a lot. Well, let's get into the specifics of it. So at the heart of trauma, you need an incident that is perceived as highly threatening, to that person's physical or psychological well-being, emotionally severe incident. The most common examples are combat. We've learned a lot about trauma through the experience of particularly Vietnam veterans, sexual assault and physical violence. So the other population we've learned a lot about trauma from are abused and neglected children as well. And it's interesting how much we've learned from two very diverse groups of people about the same phenomenon. So trauma is actually pretty common. 1/2 to 2/3 of all people in the US have been exposed to at least one traumatic event. And very often that can turn into post-traumatic stress disorder. And that's going to be part of what we talk about going forward. So this isn't exactly a unique thing or a fringe sort of thing. We'll talk about some of the measurements of that. Some of the common traumas that people have experienced. 1 in 5 Americans were sexually molested as a child. I'm sure that number is underreported, and I'm sure it isn't overreported. 1 in 4 Americans have been beaten by a parent to the point where it left a mark. 1 in 3 couples engages in physical violence. 1 in 4 Americans grew up with alcoholic relatives. 1 in 8 witnessed their mother being beaten. Very important point here. You don't have to be directly involved in the violence in order for it to be traumatic. For example, watching your mother being beaten, I don't think any of us have to think too hard about how traumatic that can be, and you're not directly involved in it. We've also seen this in the military where what people have seen has impacted them more than what happened to them. I have a good friend who is suffering post-traumatic stress disorder. He was one of the people who was sent in to take the bodies out of Jonestown, Guyana. Now, at no point was he in any sort of physical danger himself. However, just moving all of those bodies out made an impact on him. And he was a combat veteran in Vietnam. So not a guy who's probably easily scared or shocked. So I think that illustrates a couple different things. One other piece I want to bring in is that there is a cultural framing for trauma as well. There are some people who would say that being beaten by their parent to the point where it leaving a mark is culturally appropriate. That's not a discussion that we're going to be taking on here. However, the point I do want to bring up is that there is a cultural framing for it. What is clearly traumatic and out of the ordinary in one culture might be accepted practice in another. Whether it's good or not is a whole other debate. So, working with people with severe and persistent mental illness, the rates are a lot higher, like 10 times higher for post-traumatic stress disorder. Part of that is we're looking at them possibly having exposures to more trauma and more of them over time. Also, the added features of discrimination, poverty, the deficits that come along with mental illness, social skills, supports, and otherwise. It's just more likely that they've experienced more trauma in their life. So at the state hospital where I work, the diagnosis of PTSD is only over 1%. That's pretty low. I mean, that's significantly lower than the general population, in a population that we actually expect to be much higher. Now, let's not get too mad about this, and I don't want to turn this into hospital bashing. There's a bunch of reasons why that's the case. Now, It is true that until recently, the hospitals have not screened for trauma or post-traumatic stress disorder particularly well. However, the other piece is the state hospitals are really dealing with the symptoms that may be much more upfront. If someone is psychotic, if someone is wildly manic, if someone is just coming off the influence of a lot of drugs, you're dealing with that first. So you have to deal with the stuff that you see right in front of you. And it takes a while to get underneath that to get to where someone's going to talk about PTSD. It's also important to notice that in the New Jersey State Psychiatric Hospitals, people are sent there involuntarily. And it may not be, we can argue that it isn't appropriate, but it's also at very least very difficult to get information about trauma from someone who's been sent somewhere involuntarily. And I'm going to tell you my deepest, darkest secrets because I was sent here against my will. That doesn't work so well. And the other aspect is you may have clients that are very paranoid, that are isolated. They don't trust the people that they're working with. They may be very labile. So again, a very difficult environment to do trauma work. The historic argument against doing trauma work is, well, if we dig into all that stuff, we're just going to keep them here longer. And our goal is to treat them, get them stable, and get them out. And they should work on that on an outpatient side. There is logic to that. However, what we found is the people that have more of a PTSD orientation are the people that keep getting readmitted back to the hospital again. So if you don't cover it, you're going to end up dealing with it down the road anyway. So I think the better question is, what parts of trauma can we address in a hospital setting? And then how can we set the table so that when that person's discharged, they can get into that work in a maybe a more desirable setting. But that doesn't absent the hospital from their responsibility to diagnose, treat, and provide trauma-informed care. There, I'm off my soapbox now. So now we get into PTSD. Again, there has to be something that was a potential threat to the physical integrity of that person, or having witnessed it. Again, I think we all, the 9/11 example is a pretty powerful one. Many of us witnessed it, many more witnessed it than were directly impacted by it. However, you still have the capacity to develop post-traumatic stress disorder from that. And I know many people who still have that. So there are a couple different symptoms that come along with PTSD. One of them is avoidance. They may be unable to think about anything that reminds them of the event becomes triggering for them. So they don't want to think about it. They become detached. They become avoidant from everything that's in their lives and have a diminished sense of the future. It's almost like, to me, part of them stays back there where the incident was, and anything can conjure it back up again. Very often with PTSD, you hear about the term flashbacks, and it's valid. To me, it's almost like the person travels in time. They're not just seeing this thing, they're going back to it and acting accordingly. The Vietnam vet who sees the helicopter going overhead and dives into the bushes, even though it's the traffic copter, they're not just seeing a flashback. They are experiencing the whole thing, and they are acting accordingly. So other aspects of this, being increased, very easy to provoke, hypervigilant, not famous for good sleep, either getting to sleep or staying asleep, kind of the sleeping with one eye and one ear open. Because again, the person was trained at some point that that's what they needed to do. Hard time concentrating and easily set off. We always say on an anger scale, people may be operating at 8, 9, and 10 all the time. The area where what most of us would consider an extreme is their home address. So it doesn't take much to set them off. So the bottom line is that the trauma sets off a series of maladaptive learning patterns. And then this has all sorts of consequences going forward for that person. So it starts with the traumatic incident or incidents, and then the person's whole world becomes shaped through the lens of that trauma and the lessons they've learned. The world isn't safe. This bad thing can happen to you again at any time, and they operate like that all the time. Our sympathetic nervous system was designed to be kind of an on-off switch where, okay, here's the life-endangering threat on. We respond to it. We get all the adrenaline and all that stuff so that we can deal with it. And then the off switch, and we dial it back down. And I always said that people with PTSD, they're not in charge of their on-off switch. Something can hit that switch on at any given point in time. A helicopter, fireworks, someone who looks a certain way, a certain song, anything can serve as that trigger. So let's get into the Adverse Childhood Experiences Scale. And again, it's discussed in greater detail elsewhere. I encourage you to look that up. We've been using it at the state psychiatric hospitals for a few years now to start the discussion about trauma and how common it is. So the short version about what the Adverse Childhood Experiences Scale is, it's a list of 10 questions that you ask people about pretty common childhood experiences, some of those things that we mentioned before: alcoholic family, physical abuse, sexual abuse, being made to feel inferior by parents, kind of a list of 10. And for each of those 10 that you've had the experience with, if you answer yes, you get 1 point. So you end up with a scale of from 0 to 10. And so here's how the scores come out. Turns out 2/3 of people have experienced at least one adverse childhood experience. Now, again, this is just covering up to 18. This isn't covering traumatic material after the age of 18. And 20% reported 3 or more. Now, number 4 is when things start to get kind of exciting, because at 4, you start to see other things start to happen as a result of this. And what we found out, what the ACEs really taught us, is that trauma is not only one of the primary drivers of mental illness, but it's also one of the primary drivers of addiction and also medical problems as well. Take a look at some of these numbers. It's correlate with much higher rates of COPD, hepatitis, depression, attempted suicide. Now, one of the major complaints about the adverse childhood experiences scale is that it wasn't really done with a normed population. It was done with middle, maybe upper to middle class people, primarily Caucasian, in one part of the country. Now it's been replicated and redone with people in many other places. So they're expanding that database all the time. But if you selectively picked a sample that was in good shape, now imagine if they had done this with an inner city sample, in a major American city, or predominantly a group that was impoverished or marginalized population. Imagine how those numbers would be different. And where would the norm be for the United States? So these are some great questions. But the numbers are pretty shocking, even with this sort of cherry-picked population. So basically what we've learned is that we can expect the majority of the people that we serve in the mental health system to have had up close and personal experience with trauma before. A great place to start is by giving them the ACE study. Because you're talking about someone's childhood, it can seem a little more distant, and it starts the conversation. And of course, childhood is where very many of these significant traumas have begun. So what this does is it starts a changing conversation for those of us, the helper, so that we become much less judgmental of the person and there's something wrong with them, but instead we view them as someone who has survived some sort of traumatic incident, because everybody responds different to these traumatic incidences. Where I used to work, there was a convenience store near the hospital where I worked, and a person came in with a gun and held up the place. And there were 2 customers in at the time. So the customers were told to lay down on the floor, and they did. The person cleaned out the cash register. I think he fired a shot into the ceiling. No one was injured, but he fired a bullet into the ceiling to make his point, got the money out of the cash register, and ran out the door. So the 2 customers get up off the floor and dust themselves off. One of them immediately gets on social media and is like, "Oh my God, I was just in this convenience store and I got robbed." The other one became very tearful, very phobic. Afterwards was afraid to go to fast food places or convenience stores or anything like that, started having panic attacks. So what makes the difference between these 2 people that were in the exact same place at the exact same time, experiencing the exact same thing? My guess is that that person who responded so negatively to it had some sort of previous experience with trauma, and then this increased what we would call their trauma load, and this leads to this response. It validates something negative instead of something completely out of the blue, like, "Oh my God, I can't believe this guy knocked off the store." So how do we discuss this with this person? Instead of what's wrong with you, we talk about what happened to you. We're taking their side and helping them through this, as opposed to the sort of snap out of it mode that was so common to old mental health treatment. So one of the major points of this presentation is something called universal precautions for trauma. Now, those of you who've worked in medicine, I'm sure you're familiar with the universal precautions. You always glove up, you always gown up, you act as if every single person's contagious because you don't know who is and who isn't. Same deal with trauma. We assume that every person that we're treating has been the victim of violence, abuse, neglect, some sort of trauma. And as part of our right at first intake, we go there and ask about what that is. We can't help them until we get to that. Very often the symptoms that we are seeing have stemmed from that original incident. It'd be like asking if somebody can't walk and then you find out later that they'd broken their leg. You can't address their gait and their posture until you go back and figure out what the deal is with that break and deal with that. So as I mentioned before, some triggers are individual and triggers are very highly individualized, but there are some that are pretty common. There are people who don't like being ignored. There's some people who don't like being in the dark. I mean, you can get a look at these. There may be some of these that you might be hypersensitive to. I can tell you I worked in corrections for a while, and I never got used to that big metal gate clanging shut. I worked there for about 2 or 3 years. I never got used to that sound. That was a very triggering sound for me. And even though, yeah, it's just a sound, Ken, you know the door is going to close, it had an additional impact for me. It actually made it very difficult to work there for me. So just to cover some of the points that we've talked about, and again, this is just meant to be an introduction to this. There's a lot of great work on here. We'll talk about this in some of the resources, and you can check out some of other videos as well. Trauma is a result of experiencing or witnessing a potentially dangerous event. Relatively common in the United States, and I imagine it's common throughout the world as well. And people with mental illness and addictions have tended to experience more severe and more repeated traumas. Post-traumatic stress disorder is a response that can occur as a result of trauma. The Adverse Childhood Experience Scale, or ACE, is a way of detecting trauma in adults by looking at it from the lens of looking back at traumatic incidents in their childhood. And again, that main point at the end, universal precautions for trauma means as if we treat everyone as if they're the survivors of trauma. And particularly in psychiatric facilities, that extends to things like restraints and injection and confinement. Think about someone that has been the past recipient of physical or sexual assault now being restrained or being, physically accosted by somebody. It has a whole other meaning than prohibiting somebody's freedom and can set them back in their treatment. So this is where we got a lot of our material from. There's some great stuff there. Definitely recognize Bessel van der Kolk's book, The Body Keeps the Score, is a great one, but there's a lot of great stuff here to look at. Anyway, I thank you for your time. Check out some of the other videos that we have in our series. It was nice talking to you, and take care.